now I would like to introduce the next speaker. It's my honor to introduce Dr. Alexandra Gangi, which is a dear friend of mine, a wonderful person, a wonderful surgeon, she was going to discuss about surgical treatments of neuroendocrine tumors. And a fun fact about Dr. Gangi is that she raised a pandemic puppy named Charlotte. And also Dr. Gangi speaks 5 languages. I have to say, Russian, Farsi, French, Italian, English, Spanish. But yeah, welcome, Dr. Gangi.
Thank you, Dr. Del Rivera, for that kind introduction. And then she said, thank you all for being here. You're the reason that we get up in the morning and come here. So not here, but to work. So in 15 minutes or so, I'm going to try to talk to you about the surgical treatment of NETs. And this isn't necessarily tailored to one particular subtype, but some of the information is just what you should think of when you're meeting with your surgeon and what you should look for. And then we'll talk a little bit about some gastroenteropancreatic NET management. As Dr. Del Rivera went through earlier, the incidence of NETs has been kind of consistently increasing over the course of time. And here you can see the incidence increasing between the 1970s and 2012. And if you look at more recent updated data, that still continues to go up by just a tiny amount. She mentioned to you that the anatomic distribution of NETs suggests that they can arise essentially anywhere. My focus is going to be a little bit about pancreas, liver metastases, and the small bowel. But as we saw from you guys raising your hands, we have people with bronchial or lung primaries, we have people with primary tumors, and the thyroid paragangliomas, et cetera, et cetera. So one interesting fact that may be true for a lot of you that came out at World NET Cancer Awareness Day some years ago was that 1 in 2 U.S. patients were diagnosed with other conditions when they actually had a neuroendocrine carcinoma. So it's not uncommon that we see patients in my office who say, you know, I've been going to my gastroenterologist for 10 years and they just told me this is normal, or that I had IBS, or it was menopause, or whatever else. So this is a difficult journey for many of you when you finally are told, hey, this is what you actually have, and then you look back and realize, oh, that makes sense. It wasn't because I was aging or because anything else was happening. So one thing that helps with that is after your diagnosis, it's really helpful to connect with a neuroendocrine tumor specialist. And there's a number of us throughout the country. The importance here is not so much that we necessarily do things differently, but we probably can talk to you a little bit more about the importance of the sequence of events and the sequence of the way we're going to treat you based on exactly what you're dealing with, and potentially refer you to other colleagues who may have clinical trials available or have options that we may not have for you. So in connecting with a NET specialist, you get to discuss your options, why they might be right or wrong for you. This can include different types of medical therapy, surgical treatments, and other therapies like PRT, radiation, or liver-directed therapies. We don't have interventional radiology here today, but they essentially are kind of like our right hand for all of us, not uncommonly. So there's definitely talks, I think, on the LACNet's website that you can listen to about liver-directed therapies. Our responsibilities as your doctors is to provide easily understandable information regarding your diagnosis. You should be leaving our offices with a list of options, and you should have an understanding of the pros and cons of why each option may relate specifically to you. So if you're leaving my office and you don't have an understanding of why I recommended what I recommended and why I think we should do it in a certain order, then I probably didn't do my job. And ultimately, we should be working with you to create a plan. Your responsibility there is to tell us about everything. We want to know your symptoms. We want to know your lifestyle. We want to know how active you are or you want to be or you were. We want to know your treatment preferences. And I mentioned past experiences because there's a lot of people who have had patients or family members, not patients, who have had cancers. They've had a grandmother, an uncle, a son, a cousin who has had X type of cancer and they had X type of chemotherapy or X type of surgery. And so you come to my office and you say, no, so-and-so went through this and I'm not doing it. I'm not doing surgery. I'm not doing chemotherapy. I'm not doing anything. It's important for me to understand the why, right? What did you see there that makes you not want to do it? And it's important for you to hear us out so that we can tell you that it's not one size fits all. The treatments that we may be suggesting are not similar to what your family members may have gone through. And so we ask that you be open-minded about exploring these different treatment options. And how do you choose your surgeon? Like we said, try to find a specialist. Have they seen or done this before? If they said, hey, I read about this once 25 years ago, then, maybe ask if they know someone who's probably done it in the last maybe couple months, if not weeks. And usually they should be on board with helping you to find someone. Ask if your surgeon participates in a tumor board or works with other NET specialists routinely. This is important only because, like I said, the sequencing of treatments is critical, right? So it's not uncommon that we can take things out, but the question is, why are we taking things out? Is it going to help you? Is there something else that's going to help you first or faster? And at the end, you should really feel empowered to add your own perspective. As you'll hear probably today, don't be afraid to seek out other opinions. If your doctor gets upset that you want to get another opinion, definitely get another opinion. What if you need surgery? Well, question we commonly get on a lot of the podcasts and other things that we have with the patients. It depends on what kind of surgery you're having, right? The surgery that you're going to have to do a pancreas resection is different than a small bowel resection, is different than a lung resection, is different than us operating in your neck. It also depends on the pathologic features and how much disease you may have. It depends on your symptoms, if you have a functional or non-functional tumor. It depends on if you're presenting with specific symptoms like abdominal pain or bleeding. That might actually get better after we operate on you, right? As opposed to if you don't really have any symptoms, then you might not feel so great immediately after surgery because I'm gonna give you pain. And then other factors. What is your overall health? Are you healthy? Are you out there hiking 10 miles a day? Or are you not? And are you a surgical candidate, right? So in order for us to do a maximally invasive procedure where we're putting you to sleep and under anesthesia and everything else, we need to know that your heart functions well, that your lungs are functioning well, that you can tolerate anesthesia, you can go to sleep safely, et cetera, et cetera. So something like patients who have carcinoid heart disease, sometimes we can't do anything until we take care of your heart. So these are all important things that we want to look at before we discuss surgery. So let's talk a little bit about pancreatic neuroendocrine tumors. This is just really the nuts and bolts because you can spend an hour talking about every single one of these topics. And if you have questions, I'm happy to take them afterwards. When should we take out pancreatic neuroendocrine tumors? When they're functional, meaning if they produce a specific hormone, as Dr. Del Rivero mentioned, no matter what size, the tumor should come out. If they're larger than 2 centimeters and non-functional, the recommendation is that they come out. If they're under a centimeter, they can stay. Usually if I see a patient with a neuroendocrine tumor less than 1 centimeter and they say, is this a cancer? I say yes. They say, what are you going to do? And I say, I'm going to leave it in there. They look at me as if I'm growing a second head, as if you're going to leave a cancer in my body and you're going to watch it. Okay, we're going to go see someone else. So usually then I'll explain exactly why, and then we come to terms with that. But there's good data that suggests that if we watch these carefully, a majority of them behave quite well. And if we see them growing, we can always go in and take them out if they're behaving more aggressively than they should. If they're between 1 to 2 centimeters, there's some controversy. We recently had a panel of surgeons discussing the management of neuroendocrine tumors, and one surgeon got up and he said, well, what if it's 1.9 centimeters? Am I just supposed to watch it until it grows another millimeter? Right? So, there's no great answer, but at some point we have to pick a cutoff. And there's new data that suggests if you watch these tumors that are under 2 centimeters, again, we can watch them and we can intervene if there's a change. If they're isolated and non-metastatic, high-grade neuroendocrine carcinomas, we still will potentially favor taking them out after trying some systemic therapy. Sometimes if they're large, to shrink them. It's very rare that we see these in a small, isolated fashion, but I suppose if we saw that, it wouldn't be unreasonable necessarily to intervene at that point. So the current guidelines, NANETS, ENETS, multiple different societies across the country recommend observation for PNETs less than 1 centimeter, resection greater than 2, and then an individualized approach for PNETs between 1 and 2 centimeters. And then if you have metastatic disease, does that make you not a candidate for surgery? Not necessarily. It just depends, again, on how the metastases are distributed within your body. Are they liver dominant? Are they outside of the abdomen? If we can cytoreduce, meaning if we can clear out everything, sometimes we will consider that after trying some systemic therapy just to see how you respond. It's important for us to know how your disease responds to different things. Because if we go and do a big aggressive surgery and in 2 months all sorts of new things come out, we didn't really do very much in clearing and helping you by doing that surgery first. That's where that's important. And then how do we approach these? So this lovely thing is your pancreas. The red dots represent neuroendocrine tumors, as does the, I guess that's brownish one in the corner, tan. You can see that there's the head of the pancreas that kind of sits right along the first portion of your small intestine called the duodenum. There's two important vessels, the superior mesenteric vein and artery that supplies all the blood flow to your small intestine and some of your large intestine, and then it goes and drains into the liver, the vein. So it's an important structure, and everything to the right of that, essentially if you have a tumor in the middle of the pancreas, where the pancreatic duct is, then you essentially need to remove the entire head of the pancreas. And because of the blood flow, you see that one red blood vessel that's coming in and sitting on top of the pancreas and supplying blood flow to the first part of the intestine? Well, that's shared. You can't really separate the two, so they're intimately involved. So when you take out the head of the pancreas, you need to take out that first portion of the small intestine, and that's called a Whipple procedure. So if we do that, we're basically making all of these cuts where these dashed lines are, and then we have to reconstruct everything. So we end up reconnecting your pancreas to the small intestine, your stomach to the small intestine, and then your bile duct, which is draining your liver, to the small intestine, so that when you eat, you're getting all of the enzymes you need. If you have something in the tail, so to the left of these important structures, it's not really intimately involved with anything. Sometimes the spleen kind of sits up here, and it can be involved depending on where this red dot is. So with that, if it's in the middle, again, along the pancreatic duct, sometimes we have to take out the entire distal portion of your pancreas. If it's in the middle here, sometimes we can do what's called a central pancreatectomy. So you take out the middle part of your pancreas, and then you put a piece of small intestine between the two. And then this tan one is not like the others, because one, you'll notice it's a little bit small, and then it's in the periphery, meaning it's away from the center of the pancreas. So neuroendocrine tumors are typically pushers. They're not invaders, meaning they push tissue out of the way. They don't really grow into it. So what you can do is sometimes you can just come around this and enucleate it with just a little rim of pancreas and avoid having to do a big resection. And this is true whether it's, in the periphery here, and sometimes if it's in the periphery along the head of the pancreas, though that's a little bit more challenging, but can be done. What about small bowel neuroendocrine tumors, where these are the most common site in the GI tract? There's an incidence of about 10 to 12 million, and 35 to 40% of them are multicentric, meaning, this thing's very sensitive. I'll tell you what that means. But guidelines for resection, if you're symptomatic, we typically recommend resection of your primary tumor. So that's whether you have isolated disease in the small bowel, we always recommend it. And if you have metastatic disease and you have symptoms, like you have a bowel blockage, you have abdominal pain, you can't eat, the primary tumor should come out. In asymptomatic patients, that's controversial. So we have some data that suggests that there might be a benefit, but this is all retrospective, meaning these are patients who have had surgery, and we're looking back and saying, oh, look, all these patients who had surgery did better, but maybe they had surgery because they were better candidates for surgery to begin with. So it's not really a head-to-head comparison, so it's difficult to make definitive recommendations. The next slide has a graphic picture, so if you're going to be sensitive, please look down. The approach of the surgery depends on the extent of the disease and the tumor location. As I mentioned to you, sometimes these can be multicentric, meaning there's more than one tiny tumor that could be in the small intestine. So a lot of times patients will say, can you do this robotically or laparoscopically? Can I? Yes. Will I? No. The reason for that is these primary tumors, so this is my hand, it's not, I think it's normal sized. That's a picture of my hand palpating small bowel. You can see the little white spots for the little kind of grainy things. That little guy, this tiny guy right here, that one, that's a patient with multifocal or multicentric neuroendocrine tumors in the small bowel. And if I try to feel that with laparoscopic equipment, I'm not going to feel it. And on the robot, we don't actually get any haptic feedback, meaning we can't feel anything. We can only see. So if we take you to surgery and we do it that way, it's possible that we're going to miss some of these teeny, teeny, tiny tumors. So what we do is we can frequently make a small incision, and we can manually palpate the bowel that way. That doesn't mean you need something very big, but we do need to manually palpate, at least for the time being, until we find new ways of identifying these lesions. What about your gallbladder? Does it need to come out? If you have metastatic disease and we're going in there for something and we think you're going to be on somatostatin analogs, which can cause cholecystitis or cholelithiasis long term, sometimes we'll remove your gallbladder just so nobody has to go back. But if we're just going in there to resect something and we think that's going to yield you free of disease, and you're not going to be on somatostatin analogs in the immediate future, we don't necessarily go take more things despite the fact that that's what some of our medical oncology colleagues sometimes believe. What are the benefits of resection? It could be curative, can present future metastases, alleviate bleeding and obstruction, and reduce circulating hormone levels. And then a lot of times I'll kind of talk about taking out a wedge of the pie. So if the tumor is up here on top, we need to take out all of the draining lymph nodes. And then sometimes the lymph nodes are the thing that we see on the scan. So if a lymph node is up here, or a lymph node packet, and it's blocking this whole artery, sometimes we can't take that out, right? Because if we have to take out that whole artery, you're going to see that all of the small intestine would no longer have any blood flow. So sometimes that's a limitation of what we can do. What if you have metastatic disease? Metastatic disease is common, we know that. But how do we look at this? We look at this as how heavy is your tumor burden. So I'm going to talk mostly about the liver because that's what I like to operate on. But if you have a low tumor burden, kind of like you can see on this scan, and I don't know if it's projecting well, but this patient has 1, 2, 3 lesions that are visible. This is someone that we would consider surgery in depending on their primary. If someone has a heavier tumor burden, we've taken out and ablated well over 80 or 90 small neuroendocrine tumors, but then we don't usually think let's go to surgery first necessarily. What about if you have a heavy extra-abdominal tumor burden? Then we might think of some other things to get good control of everything first before considering surgery. So surgery's in there at different time points. You just want to make sure that you're doing it at the appropriate one. We usually don't want to do it if we can't take out at least 70% of the disease. Keep in mind that we're again talking about grade 1 and 2 neuroendocrine tumors. We want to make sure that you're a healthy candidate. And how do we approach these? So depending on the distribution of your tumors, sometimes we will decide what to do, right? So in this case, this person has 1 tumor. You can either take out the entire left lateral segment, but why would we do that? I just told you that they're pushers and not invaders. So you can just essentially wedge out that one particular portion. And if you look down here at panel E, this is a patient who has bilobar, meaning there's disease kind of on both sides of the liver. This central one, if we wanted to take that out, even if that was the only one, we would have to take out your entire right liver. We don't really do that anymore. We used to do that 20, 30 years ago. But now we've found ways to mitigate that so that we can preserve the liver and preserve liver function so that you're eligible for other therapies. So in this case, with the neuroendocrine tumor, we would probably favor this approach, right? Whereby we take out all of these peripheral lesions on the side, and then this is an ablation probe. We ablate the one that's central so that we're able to preserve your liver. Or we can consider liver-directed therapy for these patients. Another graphic picture coming up next. This is an example of a patient who had multiple neuroendocrine tumors removed. You can see we just are able to core them out, right? So you can see the holes in the remnant liver, and you can see all the tumors that were actually removed. With respect to the liver resection, we can sometimes do this robotically or laparoscopically. In fact, we just did one yesterday. We can do ablation in the OR. But again, this is important because it helps potentially reset the clock and we're not taking out lots of healthy liver. And what about after surgery? Again, that depends on what type of surgery you just had. What did we take out? That's why it's important to have these discussions up front. Did we take out small intestine, pancreas, liver, lung? The recovery for that, the drains that you get, how soon you get to eat, all vary based on how you're doing. How long was your procedure? And how much stuff did we take out, right? So the longer the surgery, the longer the recovery. But it also depends on your overall health. So usually before we do surgery, we talk about making sure that patients are exercising before to the best of their ability, trying to get at least an hour of walking in, whether that's in 10-minute increments or 30-minute increments. And then, making sure that they have a good, healthy diet. Because the healthier you come in, the faster you'll go out. And then you're going to have some pain. It depends on where the incision is. You're going to be expected to walk the day after surgery, because thus far we haven't operated on any leg neuroendocrine tumors. You will be started on a diet eventually. And how long you stay in the hospital depends on how well you're doing. Usually we'll see you about 1 to 2 weeks after discharge. And the appropriate members of the treatment team will continue to monitor your progress, monitor your neuroendocrine tumor, and then discuss the need for additional treatments. In between visits, you should make sure that you kind of keep us apprised of exactly what's going on, keep a log of the questions you're having, and if something doesn't feel right and I'm not seeing you for 2 weeks, please just call us, because otherwise we don't know that something's wrong. We want to hear from you. So that's kind of the nuts and bolts of surgery, and hopefully that helps provide a little bit of guidance. Thank you.